Thank you very much for having me. I really enjoyed this meeting, especially the patient component part. I'm more used to talking to my peers in medical oncology, and I hope to be up to the challenge. So when you meet with the physician for a consultation about a desmoid tumor, I think that it's good to come with some questions in mind, such as, what are desmoid tumors? If you Google, you'll see plenty of things, some more worrisome than others. What causes desmoid tumors, even if he or she may tell you we don't know? What are my treatment options? And what's my prognosis? In other words, what's the long-term outcome of this disease? The nature of desmoid tumors. So first, I like to tell my patients that desmoid tumors are not cancers. According to the WHO, they're not entirely benign either because of what they can cause. They're put in that category of intermediate tumors because they're locally aggressive. They may come back even after surgery, but they never spread, although there are cases of so-called multifocal location where the same patient may have several tumors in the different part of the body. The name sounds strange. It comes from ancient Greek. Desmos is a string, something fibrous, and that's due to the aspect of these tumors, not only physically, but also under the microscope. And when you look under the microscope, these tumors consist mostly in a proliferation of fibroblasts, one of the commonest type of cells in the connective tissue. And consequently, they can arise in any part of the body, even if, as you can see in that pie chart, that the limb girdles, the limbs, and the trunk are particularly frequent locations. What causes them? The real short answer is that we don't really know, although we do see that there may be some predisposing factors. In the meeting, there has been an allusion to traumatism as being possibly a triggering, if not a causative circumstance. There's a definite influence of hormonal factors when you think of it, because desmoid tumors are more common in women, and they tend to be influenced by pregnancy. They may grow during pregnancy and regress after delivery. Most of the cases we see in the clinic are sporadic, meaning that they just happen. And those sporadic tumors are associated with mutation of a specific gene, the beta-catenin gene, whereas the 10% of patients who have a familial predisposition are carriers of the APC mutation, which is common and actually the cause of familial adenomatosis polyposis, a premalignant condition that leads to multiple colon cancers. How do they behave? That's what you also want to know when you meet with the oncologist. And again, the answer is that they have an unpredictable behavior. In fact, they can grow as you would expect of most tumors, but they can also regress, usually partially, in approximately 10 to 20% of cases. The growth can be slow, can be rapid, can stop on its own. And one reason why, despite that unpredictable behavior, including an indolent one, we talk about treatments, is that desmoid tumors can cause complications. They can actually make people sick. They can cause pain, vascular compression, nerve compression, which lead to complications such as bowel obstruction, bowel perforation, or infections, including abscess formation, especially in the abdomen. What are the treatment options that you want to discuss with your provider? That includes surgery and other local modalities, medication, which we call systemic treatment, or observation. And you'll see that I write observation under treatment options, because observation is not just forgetting about it, but it's actively surveilling and making sure that the tumor does not evolve in a more aggressive fashion. Surgery used to be the mainstay of treatment, as for most tumors, but it can be difficult in challenging locations such as the peritoneum, the head and neck, or the limb girdles. As with most cases, when surgery is feasible, one tends to aim for negative margins, meaning reaching the healthy tissue. However, it's important to note that one should not pursue negative margins at the expense of safety. And it's also important to know that positive margins, in other words, having some tumor cells left over, does not necessarily mean that there will be an actual relapse that you can see. And if anything, even aggressive operations, which we don't recommend anymore because this is a non-malignant condition, are associated with a 30 to a 40% risk of relapse. And that's, again, a reason why, rather than precipitating onto surgery, surveillance or observation is often the recommended first step, knowing that surgery, despite its radical aspect, in fact also has its limitations. Other local modalities are on the rise. Radiation therapy is an older modality, which we tend to use less, but which can still be useful. It can be performed in lieu of surgery. It provides good symptom control. It prevents further tumor progression, but it has long-term side effects, such as fibrosis, other cancers even. And an important thing to consider is that there is no benefit to add radiation to surgery. So you choose your local treatment modality if that's the route you're taking. If it's surgery alone. If it's radiation alone, but there's no benefit to combining the two one after the other. Cryoablation is a newer technique, which consists, roughly speaking, of freezing the tumor with a probe. But there are also some technical and anatomical constraints, so which means that this is something that you want to discuss with an interventional radiologist who has the right experience for it. And there are not yet lots of long-term data in regard to efficacy and safety, but it certainly appears to be a promising modality. So in many instances, if we decide to intervene for a patient who has a desmoid tumor, we'll be talking about medications. And those medications can be roughly divided between traditional chemo, which everyone knows is used especially for cancers, and targeted therapy, which historically also comes for cancers, but are also used in other circumstances. So when we look at traditional or cytotoxic chemotherapy, the two main types of regimens are either doxorubicin-based or methotrexate-based. We don't tend to use doxorubicin in combination with other medications anymore because there's no obvious benefit that you gain more by throwing a lot of chemotherapy to the patient. So we tend nowadays to use doxorubicin alone, whether the original formulation or a gentler formulation called liposomal doxorubicin or Doxil, which is given every 4 weeks. The response rate is, about half to 2/3 of the patients will have a sizable reduction in the tumor size. And traditionally, I would say more than, because it's truly driven by data, the duration would be about 6 months. And interestingly, there will be many patients who, even after stopping the chemotherapy, will remain without progression of the tumor. Same thing about methotrexate. Methotrexate-based regimens, methotrexate can be combined with another drug. That's often what we do. And the difference in terms of schedule is that it's given on a weekly basis. It's somewhat less convenient. but it has an efficacy that would be more or less comparable to that of liposomal doxorubicin. Traditionally, again, it tends to be given for a longer time, closer to a year compared to the 6 months. And this is one regimen that has been probably more extensively studied in kids compared to the other regimens that we are discussing. The targeted therapy agents, such as tyrosine kinase inhibitors, sorafenib or pazopanib, are oral, which is obviously a big advantage in terms of patient autonomy. And how do they work? There are lots of hypotheses as to how they work. It's believed that their so-called anti-angiogenic action, which is the fact that they block vessel formation, could be part of the way they work. The response rate is about comparable to that of chemotherapy. However, despite their convenience and despite their efficacy, it has to be recognized that they can be sometimes difficult to tolerate. So side effects are not unusual, such as fatigue, rash, high blood pressure, thyroid problems, which can be managed by good cooperation between the patient and the physician. Because those agents are more recent, the optimal duration of treatment is not well known, but it's becoming common practice to anticipate that these treatments will be given for a given duration of time, say a year, maybe 2 years, and to consider stopping after. Because again, experience shows that it's as if the tumor had been stunned after receiving treatment. Many patients will enjoy if not a remission, but an absence of further progression, sometimes for a good time of treatment. Nirogacestat is the newer kid on the block, and in my view, it's another kind of oral targeted therapy, even if the target is different. It blocks signals that are needed by the tumor cells, the Notch pathway, and it has been recently approved in the United States, not even a year ago. It's an agent that also shows a good rate of response. And I want to emphasize that when we talk about response in oncology, we are talking about a tumor reduction size of at least 30%. So the bar is high. But I want to emphasize that even if you have a size reduction that's lesser than 30%, if you have stable disease, that's still considered a benefit that you're having from the treatment. So don't think that it only means that 40% of patients benefit from the treatment. The reality is much higher because we should include those who also those who also have stable disease or destabilization after treatment. As any other drug, nirogacestat also has its toxicity. Many patients complain of diarrhea, skin rash, mouth sores. We talked a moment ago about ovarian toxicity, and many of those side effects can be managed with supportive care or, if needed, a dose reduction. Again, the duration of treatment is not well established, but consideration is being made to treat patients for a defined duration if possible. Observation, in my view, as I said earlier, is not just forgetting about the patient or forgetting about the tumor, but it's an active way to manage this disease. And the rationale for it is that astute clinical observations that have been corroborated by rigorous clinical research confirm that desmoid tumors can sometimes shrink on their own or remain stable for a long time, even without any intervention. And therefore, watching them with a regular clinical and radiological evaluation that allows us to defer treatment and to defer the toxicity and the inconvenience and the cost that come with treatment. And in fact, observation is being more and more adopted as the first approach. So in conclusion, you should ask yourself and your physician, what's best for me. And in that optic, I would strongly recommend that you be seen at least once in an expert center, in a center where there are many cases of desmoid tumors that are seen, to provide guidance, not only to yourself, but also to your treating team if your treating team is closer to home. Ideally, this consultation will be a multidisciplinary meeting where you would meet or where you would get input not only from the medical oncologist for medication, but from other specialties that could eventually be involved, such as surgery, radiation oncology, and I even say radiology, pathology, etc. If there are no symptoms, if the tumor does not appear to grow, if it doesn't threaten important or critical anatomic structures, it's quite reasonable to consider observation or surveillance as a strategy. And if there is a need to treat with medication, then you need to have a good conversation with your medical oncologist as to which drug would fit your case. Unfortunately, there is no high quality comparison between the different treatment medications that I have shown you, but experience from the physician and consideration about your particular situation can help us choose what we think, is the best treatment for you. So there really needs to be a partnership between the patient and the care provider. And that's what I have to say. Questions, please.
Write it down. So I was diagnosed 3 weeks ago. So I was diagnosed 3 weeks ago with 3 tumors in my abdomen, 1 in my mesentery and 2 like somewhere else down in there somewhere. And I met my oncologist a week ago and asked if this was cancer, and the answer was no. And I'm confused by that because the treatment modalities for these tumors seem to resemble the same treatments that cancer has. I've had close friends of mine who have had cancer or no longer have cancer, but I'm being told that I will have these tumors possibly indefinitely. So the reason I ask this question is because I feel like I get shrugged off when it's not considered cancer. In fact, the word benign is used quite often. So do you see this possibly coming into the conversation of desmoid tumors being classified as a cancer anytime soon or ever?
So I think that it's a very important question because I find that the word benign sounds very benign precisely. So, when I, as oncologist, I think of a benign tumor, to me, it means I don't need to worry at all in any way. Okay, like a lipoma, it's really benign. You remove it and that's the end of it. It's not a cancer because cancers tend to threaten your life in a more immediate way. They behave aggressively, not only locally, but also at distance. Cancer spread and cause metastasis. And that's the reason why the WHO, the World Health Organization, calls that tumor and others in the category of intermediate tumors. They are not cancers because under the microscope, they don't have the features of cancer cells. And clinically, they fortunately lack some of the features of cancer, such as spreading to other organs. But I agree with you. They are not just benign, and you can't really shrug your shoulders about them because yes, they cause complications. people get sick from them, and that's why they require treatment. The treatments that we have, you're right, are treatments that we also use for cancers, but that does not make them cancers, you know. And I think that it's very important to make that distinction, that we're dealing with a kind of tumor that is locally aggressive and sometimes requires an aggressive management, not always, but in most instances, it's not going to interfere, okay, with your life expectancy in the same way as a cancer would.